Hello, and welcome to the Behavioral Health Matters podcast with Magellan Behavioral Health of Pennsylvania. This is the show that aims to promote positive mental health, increase our understanding of behavioral health topics and services, and reduce stigma. I'm your host, John Lees, and I'm the member and family advocate at Magellan of Pennsylvania, here in the Lehigh Valley. On this episode, we'll be discussing the role of the medical director at Magellan of Pennsylvania with our special guest, Dr. Chris Squillaro, Medical Director at Magellan Behavioral Health of Pennsylvania. During our conversation, Dr. Squillaro shares his background, including how he gravitated toward the field of psychiatry. He also shares some of the work he did while working for provider agencies and how it helped to shape the work he's doing today at Magellan. And be sure to stay tuned at the end of this episode to learn how you can provide us with your feedback about the podcast and make suggestions for future episodes. This episode includes discussion about drug use, addiction, and suicide, which some listeners may find disturbing. Listener discretion is advised. And now here's my conversation with Dr. Chris Squillaro. Hello there, Dr. Squillaro, and welcome. We thank you for joining us on this episode. If you would, could you provide a little bit about your background for the listeners as a starting point? And you can maybe touch on your role at Magellan, but of course we'll get much more into that as the episode goes forward.
Yeah, sure. Thanks, John. Not a problem. People love talking about themselves. I'm no exception. I was born actually in Philadelphia. My dad was in dental school at the time, so I was, early years in North Philadelphia, and then we moved around a little bit. He had some time that he had to pay back to the military, and so I lived on an Army base, and then not a lot of transitioning, but ultimately landed in Ambler. Lived on a street right next to Temple Ambler campus, and really had a lovely, upbringing there. I'm the oldest of three, so I have a younger brother who lives in Miami, and then a sister who lives locally as well. Was fortunate enough to go to some schools. I started off in the public school system, but they actually didn't want me to stay because I was diagnosed with ADD at the time, and I couldn't sit still. And so by the time I was in third grade, I still couldn't read. And they were concerned about that. So my parents took me out of there and were able to put me into a private school where I eventually started to thrive. But the ADHD thing really kind of was a problem for me all through high school. It affected my maturity level. It affected my ability to do well in school. So I struggled throughout. And then it wasn't until I got into college where I had a little bit of academic success. I was an English literature major. It was the only class I did well in high school. I didn't know what I was going to do when I left college. I thought maybe go to law school, chose not to. And then, when I did leave college, I was a little lost. I went and I worked in DC for a little while, worked at a public relations firm. Wasn't happy with that, didn't like the lifestyle that I was seeing, but I really had no idea what I wanted to do. So somebody just said, look in the paper and find a job that suits, what do you like to do? And I knew I wanted to work with kids, and I knew I liked the woods. And so I was like, well, I'll look for a job in the woods that involves kids. And I'm like, there's no way I'm going to find this. But it existed. So there was a place in Western Maryland, on the border of West Virginia, deep in the woods, called New Dominion, where I was able to interview and ultimately agreed to take a job there as a counselor. And so it was an experiential education program. And it was a place for kids to go who had, they were coming from the judicial system. And so they were given a choice between either going to this 18-month program or remaining in juvenile detention. And so it was a really transformative experience. But the thing that really got me moving in the direction of psychiatry, and this is where I got my interest in psychiatry, was a psychiatrist actually came on site And they were picking up on stuff that it took us months to learn. And so I just was like, wow, I think I want to do that. I think I want to be able to do that. I want to understand this way better. So I totally pivoted. And so I was like, could I do this? And I got a lot of support from people around me. And so I figured I'd give it a try. So I went back and had to take all the classes to do my MCATs, and that's how it evolved. But the other thing with that experience was I had a partner who the two of us began to watch. We became really curious about the fact that these kids would have somatic issues. They would have pain, things that they would come and seek, some soothing for. So we didn't have medicines, but we had a big bag filled with like Band-Aids and throat lozenges and basically first aid kind of things. So we started to notice that when they would come and request something specific at night, when we huddled up and had some deeper conversations, a lot of times they were talking about specific things. So him and I started to track these two things, because sometimes they would talk, sometimes they wouldn't. And when they were really struggling, and then they would say, come up and ask for a throat lozenge because their throat was hurting, we kind of knew there was an issue going on, with a parent, a sibling, something was bothering them. And so we began to use that as like a cue to start to engage them in a conversation that they didn't, necessarily, they either weren't ready to talk about or had not become aware of the fact that this was something they needed to talk about. So, it really kind of, my interest, and this became pivotal when I decided where I wanted to go to medical school. And then so I had a choice between going to an allopathic school, which would be an MD degree, or an osteopathic school, which is a DO. And so osteopathic manipulative medicine is where you kind of take this holistic approach to people, but you actually do adjustment on the body to improve functioning. And the big thing was the body heals itself. So you want to put the body into a position to heal itself. So I loved that. I loved learning about that. And so when I kind of had to pick a path, I really wanted to be an osteopath. And so ultimately ended up at Philadelphia College of Osteopathic Medicine, and was able to get through medical school and then into residency program at University of Maryland and Shepherd Pratt in Baltimore. Did my 4 years of residency there, and was in my first job out of residency for 12 years at an organization called Penn Foundation in Bucks County. I was medical director there. I did everything there. Did it all: drug and alcohol, older adult, outpatient. And I did consults, and I worked with my medical colleagues. And so this kind of fostered, again, that same kind of connection to mental health and physical health. And then, real quick, kind of went from there to Horsham Clinic for a little while, and then and then here to Magellan. I'd been on the credentialing committee for Magellan for several years, so I knew the company. I knew people here, and when this position opened up, I was able to move right in, and I've been here since. I've been here since, I think, for almost 4 years now.
Thank you so much for sharing your background and the origin story behind how you became a psychiatrist. It gives us some great context, and it really tees up our conversation perfectly about the work you're doing right now at Magellan. And we'll get into that right after this. And now, a brief word from Magellan. If you or a loved one are a Magellan of Pennsylvania member and have any questions about services, please visit www.magellanofpa.com for more information. And now, back to the show. So let's talk about some of the areas of focus within the organization, and we can start with integrated health. What is it, if you could provide maybe a basic definition? And then why is it important to focus on integrated health as it relates to behavioral health? And then also, if you can touch on how Magellan interfaces with the providers and other folks within the community to really make sure that integrated health is a point of emphasis when it comes to the care for members?
Yeah. So, if the interesting thing is if we did this really well as a country and as a health system, we probably wouldn't even need to be talking about it. There are definitely challenges that we've had to overcome. And I think one of the biggest ones is that for a lot of times, behavioral health is not necessarily something that is a huge part of medical training. It certainly isn't a huge part of residency training. So if you're becoming a primary care physician or an emergency room doctor, it's not really a huge component of your training or education. And I think there are movements to try to change some of that. But the reality is that when they get out into the world and are actually practicing as an attending, it's a large part of what they're doing. And so a lot of people go to their PCP for behavioral health treatment. The emergency room definitely is where they see mental health, substance use. They see, behavioral issues come in there first. And so, you've got people who really didn't know that much about behavioral health now being on the front lines of trying to manage it. And so, and conversely, you've got behavioral health and psychiatry. I went to medical school. I did rotations in medicine and neurology and emergency room medicine. So I had a fair amount of experience with physical health. But once you start to really get into your psychiatry training, you're not using it all that much. So you begin to lose it a little bit. So now you've got two groups of people that, and really just taking a step back further, you've got a lot of people struggling with mental health issues also have comorbid physical health problems. Each group is kind of forced to look at something that's not their area of expertise and manage it in some way. And so the idea of integrated health is to improve that communication, improve that understanding and knowledge base. The more we look at it, and this is not new information, this has been going on for years. People have been looking at this. When you have a physical health issue and a mental health issue, both the cost to care for that person, the problems that they face are different. Just even their ability to access care becomes a bit more of a challenge than if not. So their outcomes a lot of times tend to also be a little bit worse as well. So, one of the statistics that is out there is that, somebody with a severe mental health issue has a 25-year less life expectancy. And so those are the goals of integrated health, is to change that, to reverse that situation, to improve education, knowledge, and communication between physical health and behavioral health, and really just kind of create that language and open communication and understanding that isn't natural to what's happening in healthcare right now. So that's a big part of what integrated health is. For me, I as I said before, it grew with my interest in psychiatry. I never felt as though I viewed things any other than as being integrated. And the experiences that I had in residency, I got along very well with my medical colleagues. Psychiatrists are weird, John. I don't know if anybody's said that before in the podcast, but we can be a weird group of people. And so I had, my friends in my residency program, we actually we were able to have really good relationships with our medical counterparts. And I guess we were less weird, maybe. That's what it was. And so we had a lot of good relationships, and that continued to grow our interest in knowledge, because we were talking with them about medical stuff. They would ask us questions about behavioral health stuff. And so I saw pretty early on that, having familiar relationships with people in medicine and them feeling comfortable to have a relationship with us was really a bit one of the bigger barriers. at Magellan, we have a department, an integrated health department, but they also have a pipeline right into the physical health MCOs, so that we can improve communication that way. And from one of the challenges for me at least with working at a place like Magellan is that our relationships are with our providers, and it's with the physical health MCO. So I'm not really able to interact all that much with my physical health colleagues, but it my role now is to try to facilitate that conversation between other providers.
So it seems like while not a perfect system, certainly there's improved communication and a greater focus on trying to see the whole picture and designing the treatment plan that's going to take into account all of that individual's needs, whether it be behavioral health or physical health.
For me, that's the focus, is on how do we get people treated and the care that they need and treated the way that they need to be treated. And there's always obstacles to that. It should be easier, but it's not. The day-to-day lives of docs and providers and staff, that tends to kind of get off that topic, and then our job is to come in and try to get them right back on it.
Well, I'm very glad that that's a role that Magellan is taking a leadership position in, and that providers, it sounds like, are willing to engage and do that work. And I think it sounds like that's made some progress. There's still some work to do, obviously. But if we could shift gears now and maybe talk about substance use disorders and substance use treatment. So looking at the current landscape, wondering from your perspective, what are some of the unique challenges facing providers and the entire system kind of overall? And we had done an entire episode on the opioid epidemic, which is, of course, a really, really big deal. Of course, that's not the only thing going on, of course, but just want to get your perspective on substance use disorders and current kind of the current landscape as it relates to treatment and support for those within the system. And again, I recognize it's difficult to have this conversation without talking about the opioid epidemic. It's a really big deal, but of course, it's not the only thing as it relates to substance use.
It's definitely not. But so I was doing drug and alcohol treatment during the evolution of the opioid epidemic. It was an early interest for me. I got my Suboxone waiver back in the day when you had to have a waiver to be able to prescribe it. I got that before I'd even left my residency program. I wasn't sure I would like that type of treatment, but I ended up actually loving it. And and I started to see over the opioid epidemic that as a system, we are at a disadvantage. We are trying to stay current and up to date with what people who don't have good intentions are trying to do with substances to sell them. And so, during the opioid, the evolution of the opioid epidemic, I saw, when I first started, heroin was what everybody was doing. And then, heroin became heroin mixed with other things. And then heroin became heroin mixed with fentanyl. And then next thing you know, no one's using heroin anymore. Everybody's using fentanyl. And then fentanyl becomes carfentanil. And then now we've got this xylazine problem, the zombie drug. We are behind the eight ball in a lot of these things. And so if you just look at xylazine, it's been in this country for years and years and years. The whole system was perplexed by what was going on with trying to detox somebody who was coming in on fentanyl, because they would have a longer period of time before they would go into withdrawal. They would have a longer period of withdrawal, and it didn't fit into the mold that was there. It was a head scratcher, and no one really kind of understood why this was happening. We were guessing maybe the fentanyl was different. And then, when the xylazine started to come out and you had the xylazine wounds, and there was really now, talk about integrated care. uh, that population of folks using xylazine, they need integrated care desperately, because they have, physical issues on top of the mental health issues that come along with substance use, and then they also have the substance use issue. So it really kind of evolved, and I think that's one of the bigger challenges, is that we can't keep up with the people making this stuff. We are constantly playing catch up, and the most disturbing realization during the opioid epidemic for me was when I realized that dealers who had a lethal a dosage, if they had somebody who they sold a product to pass away, they actually got more business. It's like the opposite of every business model that ever existed. If they had someone overdose on their product and die, boom, they became the go-to person, because it had to have been so powerful that it caused somebody to have an overdose. So I think that's, if you're trying to combat what's going on with a business model that looks like that, we're like I said, we're constantly playing catch up. One of our things is to try to keep in constant contact with experts. And so we had a forum where we had, medical directors from provider networks, provider organizations who did primarily drug and alcohol treatment. We would have them meet with us on a certain cadence to try to understand what they were seeing. Sometimes that led to them saying, hey, I heard about this guy who's doing this really cool treatment or has this really interesting perspective. And then we would chase him down and call him and say, hey, what are you seeing? So we were slowly trying to catch up to what people were seeing, and disseminating that information among the providers as quickly as possible. Because we knew something was off, but we didn't know what it was. And then when the xylazine came out, we were like, oh, that's what it was.
So it seems like things are so fluid and dynamic within the field of substance use that really the goal, and of course Magellan isn't providing the direct care, but supporting those who are. And it seems like the goal is to make sure that information is being shared related to best practices, available trainings, and just providing that communication and collaborative support for the providers to ensure that folks out there are receiving the best possible treatment, and really trying to keep up and maybe even get out in front of the issues that are facing those within the system.
And I think the how people conceptualize substance use disorder and the combination of issues that go along with it has changed too. And so, when I first started providing care in Pennsylvania, it was the PCPC. Now it's the ASAM, and the ASAM's on its third edition and now on its fourth. And so the definitions, the kind of the way folks need to be treated is changing. I think a lot of the challenges are changing as some of these substances are getting more and more potent. They're having more and more physical consequences. They're having more and more mental health consequences. And so what is being put on the street is rougher for people. So recovering from it is rougher as well. And then you've got providers that are also trying to understand what is the latest and greatest way of doing this. And for us at Magellan, because we're not treating people directly, we rely desperately on documentation. That has been my plea to providers since I got to Magellan, is please, please, please document all of the good work that you're doing, because I know you're doing it. I just don't know you're doing it because I can't read it. It's really important, because that information then becomes a part of how somebody else is going to maybe use that information to help treat that person the next time.
So again, that theme of communication and really partnership and collaboration is really critical to ensuring that the system overall is doing everything possible to provide the best possible care and treatment for those who are in need of it. And it seems like Magellan, again, is at the forefront of ensuring that that's happening and facilitating a lot of that collaboration and those partnerships. And now, a brief word from Magellan. Are you or your child a Magellan of Pennsylvania member? Have you received behavioral health services? Is the quality of those services important to you? Well, Magellan has an opportunity for you to help improve the behavioral health system. You can serve on a complaint or grievance panel, allowing you to have a voice in the behavioral health system. If you are interested and want more information, please contact John Botker at 877-769-9784. That number again, 877-769-9784. And now, back to the show. So moving to a new topic, specifically social determinants of health. I know that over the past few years, Magellan has worked very closely with the counties and Commonwealth of Pennsylvania on social determinants of health and the impact on mental health in particular. But I'm interested to get your perspective, particularly since we've already touched on that total health view, the medical and the behavioral health. So from your perspective, in terms of social determinants of health, as it relates to things like care delivery, the support that the team provides, kind of the activities of the team as it relates to social determinants of health, and then your role within that context.
Yeah. So, and I think you said it, well, you did say it, that social determinants of health, if you're not looking holistically at a person, if you're not looking at the things that happen in their social life and the world that they live in when they leave your office, you're just not doing a holistic job. So that it's taken a while for everybody to kind of catch on to that, but it really is, it's that critical. And so the way I look at it is like this: if I'm a psychiatrist and I'm working out in the community, I may be seeing somebody once a month for 15, 20 minutes, and then, eventually stretching that out maybe once every 2 or 3 months. In all, I may be seeing somebody the same amount of time with somebody as they may get with their therapist in 2 sessions. That's how much time I get with them over the course of a year, is for the therapist, what they do in 2 sessions. And then if you expand that out, as soon as they leave my office, as soon as they leave their office, all of the rest of that time, they're existing in their social environment. And that's where we rely on some of the things that we're doing to solidify. So if somebody's working therapeutically with someone, that's the environment that they're tested in. That's the environment that they actually practice the things that they're learning, and they really integrate themselves what they're learning and having pointed out in their own therapy. For us prescribing meds, it's the same thing. I prescribe them a medication in an office. They don't take it till they get home. And so them seeing how that helps them interact with their world is really critical. And so if you to sort of think about it, when I'm seeing somebody, I have a fraction of a person's time, a very, very small fraction of a person's time, to try to help them figure out how to make changes that will affect all of the rest of that time that they have. Because that's really what we're looking to do, is to make that time the best that it can be. Because that's what, a lot of times makes life worth living. The people that we are around, the things that we do. So really this requires a lot of assessment of what's going on. And I think you can even go as far as saying, if you go to the biopsychosocial model of treatment, and I add spiritual at the end there too, not that it needs to be religious, but it just needs to be something grounding that keeps people, that keeps them grounded, that allows them to take a break from the world for a little bit in every way that they do that, whether it's prayer, meditation, whatever it is that they want to do. I think that that's an important component of it as well. But what you find is that if these four things are out of balance, a person will feel out of balance. And so you have a social issue that could be contributing to your physical health, that could be contributing to your mental health. You fix that social issue, and now all of a sudden you've got a better chance of fixing the physical issues and the mental health issues. And so it is, to me, no different than treating their mental health. If you're not addressing the social issues that drive their existence, you might not be changing all that much.
So it's that full picture, that total person view that, again, is so important, it seems, to making sure if we're going to focus on behavioral health and mental health treatment, we really have to be looking at the person in total. And there are a lot of different kind of domains that make us who we are. So you mentioned spiritual. I know there's the physical, emotional well-being, social, how we're doing socially. All of these things can really affect, how we feel. So if we're off in one of these domains, it can really impact our functioning level, I would think. And I would think that it sounds like, the focus of the team and yourself in really emphasizing social determinants of health is just that, to make sure that we're paying attention to the full person, the total, the total person, all of those domains, and ensuring that they're able to address any particular issues in one of those domains so that the person can get the most out of their mental health treatment, really maximize their care. And conversely, if something maybe is missed or isn't communicated by the person receiving the services, by really focusing on social determinants of health and having those conversations, you can bring that into the discussion, and it might help to kind of maybe unstick what might be stuck and really allow that person to move forward with their treatment by addressing one of these other areas, these other domains.
And it's, I think at the root of most of kind of any chronic issue, it is just that chronicity. It's the amount of time that somebody has to deal with something that is uncomfortable. And so whether that's a sprained ankle, if a sprained ankle never gets better and you're constantly walking around with that pain, eventually that's going to begin to affect your mood, your mental health. You're going to be anxious about things you wouldn't have been anxious about. Stairs now all of a sudden look different. It is going to affect. And so it's the same thing with social stuff. And so addressing that social factor, it is uncomfortable, because a lot of times people are scared to change things. So, if you're living in a house, and it would just be so much easier if you moved to a house that cost way less, that sometimes isn't that easy. It's easy to say, it's harder to do. And so taking that leap, getting out there, it's easy to say, hey, you need to get out there and make some friends and meet some people. But that's not that easy to do, particularly nowadays where everything's virtual. But that can make a huge difference in how they see the world, how they see themselves, how they see their mental health, how they see their physical health. So, just really, really critical. And I think, that is 100% something that we are focused on in every time we have touch with a provider. When I look at our care manager's notes, they're always asking about food insecurity. They're asking about housing. They're asking about all of these things. So I think as a system, we are reminding each other about this all the time, keeping it top of mind. And that's really how you begin to have impact. And you're starting to see a lot of resources that are becoming, like, there's lots of apps now and vendors that organize resources to help with social determinants. And so I think we're only going to get better at it. But it is still, it's like integrated health. It's a challenge that it's holistic. It needs to happen. And you're not really treating somebody unless you're considering it. And so, yeah, I think we will get better at it, but it's a slow growing process, because the demands, far outpace the resources that we have. And so it's as we get these resources, ideas, find out what works, find out what doesn't work to improve this for people. That's going to take a little bit of time to get caught up.
Yeah, I mean, I'm glad to hear that it's a focus of, it sounds like, everyone within the system. Obviously, there's clearly work to do, but I do think it's great to hear that social determinants of health are a main focus of a lot of the work and the conversations that are happening within the system. So I want to talk about a different topic now, a challenging one, and that's suicide and suicide prevention. It's a difficult topic, as I said, but an important one and something that we need to address. Obviously, most of the people within the system are aware we've seen an increase over the past few years in terms of suicide. And so I wanted to get your perspective on the topic overall, kind of talking some of the basics in terms of accessing care and various treatment options, but then also too, kind of a bigger view from the Magellan perspective and the work that you do, how the teams work with the larger system of care in terms of interfacing to help to address the issue of suicide and really working on suicide prevention efforts.
Yeah, so something that you said is that this is a hard topic for people to talk about, and I think that's really probably the first thing that should be addressed, is that it shouldn't be. When I went through my psychiatry training, we were taught there is no question that you can't ask. You may not get the answer that you want. You may not like the answer that you get. Somebody may take exception to you discussing it, but that is all more information that you then get to use to help figure out what's going on with that person. So the idea of being, this is something, we should all be talking about, not all the time if there's no concern, but when there is concern, this is something that should be readily talked about, because, people who are in that position have been dealing with something silently, most likely, that they have not been able to vent, that they have not been able to really engage whatever supports they have to help them work through. And they're on this roller coaster of, feeling very intently about doing something, and then that kind of tends to go away for a period of time, and then it kind of comes back up. And so that it's like a roller coaster of these emotions and the thoughts of maybe doing it. They start thinking, would people be better off without me? The answer to both of those is no. And they develop these thoughts about the world being better off without them, without ever checking with the world to see if that would be true. And so that's where you get to have a communication with somebody. And if we can kind of just make it that's what people start to do, I think we'd see a lot less. But in terms of suicidal thinking in and of itself, it's not a constant thought that stays at a high level of intensity. It may always be on somebody's mind, so somebody who's chronically thinking about it, but really the difference between thinking about it and then actively taking steps to do it are very, very different, and they don't exist on the same plane very often. You have to and so when you get to the peak of that thinking, and somebody is at that stage where they are feeling as though they're actually ready to commit to making a suicide attempt, typically that feeling will not last very long. It only lasts, anywhere from 20 to 45 minutes. And so getting them to find alternatives and buying a little bit of time for their brains to kind of recalibrate, for, more rational thinking to come in, is what we're trying to do, which is why, I think when you look at where, the types of methods that people use, and the most successful methods are the ones that don't you don't have a lot of time to think about how to do it. So, you think of firearms. It doesn't take long to load one and discharge it. So that becomes a really lethal mean. Um, and so a part of what, if you're on the periphery of somebody who you think may be struggling with this is being aware of that environment. Are they bringing things into it that could be used in an attempt? And so if I'm thinking that I am going to commit suicide in a certain way, but I got to go to the hardware store, I got to go do, I got to hit 2 or 3 stores before I can do that. By the time I get back, there's a really good chance that I'm not going to want to do it anymore. And then if I have all that stuff there ready for when I am kind of peaked again, then it becomes a lot different. So people, I think a way around that is to begin to, again, communicate about it when loved ones, when people who care about folks who are considering this see things differently, they see changes. It becomes important to communicate. So, I mean, if I could undo any aspect of this, it would be the fact that people aren't talking about it, and that there is a fear of talking about it. And it was interesting. We had a meeting with Dr. Adair at the state level, and he had brought in some of the folks that were pivotal to developing the Columbia suicide screener. It's now kind of the gold standard of assessing risk for suicide. And I hadn't really thought about it like this, but what they were saying was that, anybody should be able to ask these questions. And so if, somebody looks sad at a gas station and the gas attendant sees them, they should have some semblance of how to maybe assess this a little bit and talk about it. We're in schools, in every environment where somebody could present and have some behaviors that may look different. To be able to assess this would be critical. Right. It really is. I think something that the more we can get that out there, the better that is. And so, when it comes to Magellan and what we do, we work with our corporate headquarters and our corporate teams to think about this problem, because obviously it's not just an issue in Pennsylvania, it's an issue nationally. And so we've really started to look at how do we get technology to help us figure this out. Is there a way that technology can be used to identify somebody at risk for this? And so we've been doing that for a few years now, where we have a vendor who does artificial intelligence. That's their thing. So they try to predict based off of the information that we have in our system. And so we've been using that, tweaking it. We still talk about it regularly. Obviously, if somebody had figured out exactly how to do this, everybody would be doing it. Until somebody gets to that point, we're all practicing and trying and seeing if we can kind of come up with some, computer algorithm or combination of things that we can kind of say, this is the most at-risk person that we have. And so, technologically, we're trying to address it that way. We are trying to standardize some of our processes, again, when we feel like somebody is at risk, so that we're having, more touch. So we're talking to them more. We have care managers that do that. And then we are also looking to connect them and make sure that they're connected to their care quickly, that there is not these delays, because somebody, they may leave inpatient, they go into the outpatient world, they may not make their first appointment. Now all of a sudden they're in jeopardy of running out of meds, and then things go right back to where they were. So we stick with them. And really a good predictor for suicide attempts is to have had one to begin with. And so we really identify folks coming into treatment that have had an attempt, and then because they're the ones most likely to do it again. So we stay on top of them and try to keep in constant communication with them until they are established with a provider who then takes over that role. And so that's some of the stuff that we're doing to try to make a dent on that. We also work with a lot of our counties. This is top of mind for all of our counties. They are perpetually trying to find ways to improve to decrease the number of people that are actively committing suicide. And so, and you can see nationally there's the 988 number that is being utilized. So, which is a great idea. We all know 911. If we're having an emergency of any kind, we call it. To have a similar number for mental health issues is great, and that's only going to get better. So I think those are the biggest ways that we are looking at this in Magellan is, and again, trying to get people assessed and then into the resources that they need.
So clearly there's a lot of attention being paid to this issue, and you mentioned the state and their the work that they're doing, of course Magellan and the work that we do and our providers as well. And so all these resources are really important, and raising awareness about what's available also critically important. And we'll actually have an ad on this episode for 988 and that resource for folks. I think for me, the biggest takeaway really centered around communication and having these conversations. We talked at the top of this segment about how they can be difficult conversations to have, but they're very important. And from my view and from what you've shared, they could certainly change a life or even save a life.
And I think the fear there, and I've talked to colleagues, I've talked to other people. The fear is not is if they say yes, they start to feel responsible for it. They start to feel like they need to take some sort of, they almost don't want to know. I mean, there's a saying in medicine, if you don't want to know if somebody has a fever, you don't take their temperature. I think that's a flawed thinking when it comes to suicide, because if you're not asking, then you don't know. And their answer may be no, but they may give it to you in such a way that you go, that just doesn't, like that. Yeah. No was not, there's something going on, and you don't need to know what it is. You just need to be able to get them to the next person who can help them. And so I think that's why communication is so important, because we also need to train ourselves not to be afraid of the answers, whether they're positive or negative. And then the trick is knowing if it is somebody who is, positive for suicidal thinking, what to do.
And now, a brief word about 988. Are you or a loved one feeling overwhelmed or struggling with your mental health? Well, you are not alone. Call or text 988 for help. Trained counselors are available 24 hours a day, 7 days a week to provide support and resources. Remember, help is just a call or text away, and that number again is 988. And now, back to the show. So one of the primary missions of this podcast is to reduce stigma, and stigma related to mental health and substance use. And I'm interested to get your perspective. You've been doing this for a while. So, I'm wondering if you've seen over the arc of your career, as it relates to stigma and mental health and substance use, whether or not we've made any gains within the system. Are we making any headway at reducing stigma overall with mental health and substance use?
Yeah, absolutely. I mean, and I think, I'm Generation X, whatever that actually meant. And so, we grew up a certain way. We grew up with a certain line of thinking. And so to change that is sometimes tough. People get dug in, and they tend to stay in their lane when it comes to those things. So when I look to see what the really the future of understanding these kinds of topics are. So something like stigma, I don't look at necessarily my generation. I don't necessarily look at the generations before me, because I think they have pretty solid ideas. You may be able to sway them a little bit one way or the other, but overall, you're not changing that much of how they view this stuff. So I think for those generations, it becomes harder to, you know, influence the stigma. But when you start looking at the younger generations, they don't have a lot of the same issues around stigma. You will hear kids. I have teenagers. You'll hear them talk openly about mental health. You'll hear them talk openly about other people's mental health. They're not afraid to say that they're in treatment. They're not afraid to say that they take a medication. They are. So I think in terms of that, the future's kind of bright. I see each generation benefiting from the work of the generations before them. And so I think I think that's the formula, is that, we're not going to do a 180. It is going to be a slow progression over time. And it's looking pretty good, because each generation is getting better at this as time goes on. So I think eventually the idea of stigma will not be a barrier. I think for some people it is, and I think that's, generational to some degree. And so I think it's heading in a positive direction.
Yeah, that's really great to hear. And it resonates with me based on some of the experiences I've had and the work that I do. So I tend to agree, and I'm glad to hear that affirmed in what you're seeing and experiencing as well. And that does give me some hope. And so that brings us to the portion of the episode where we ask our guest if there was any one key takeaway or message they would want to leave the listeners with from the episode, what that would be. And I know we've covered a lot of ground, so it's hard to boil it down to just one thing. But if there was one key takeaway, what would that be?
Yeah, so I mean, I think my way of looking at the world is I try to identify themes, patterns, things that I see that are kind of consistent, and then it generates conversation, questions, thoughts, whatever. So if I look at the time that you and I have spent together here, I think the overriding theme has been communication. It's been important for providers. It's important for insurance companies. It's important for physical health, and to talk to mental health and SUD to talk. It just, communication is, I mean, human beings wouldn't be as evolved as we are if we didn't communicate. So to then all of a sudden say, well, great, now that we have the ability to communicate, we don't need to do it anymore. I don't think that that's true. And I think we're seeing a lot of some of the issues that we're having that are new in the world and in our communities, because communication has changed and become way less interactive, social. It's becoming more digital and remote. And I think there's a consequence to that. And if good and bad, I mean, if I don't really care how I'm informed if somebody's struggling. If they want to text me, text me. You want to call me, call me, as long as you're doing it. So I think there's good and bad. And so if the new technologies make it easier for people, great. If not, do it old school and actually open up your mouth and start talking to somebody. But I think if that to me is what we've been at the root of discussions of this podcast. To me, it is the most critical thing. And as a psychiatrist, it's really the only tool that I have. There's no blood tests. There's no genetic test that tells me everything. It's communication. It's my ability to talk, hear, listen, understand. And it's that person's ability to kind of walk through their feelings and emotions, symptoms, the things that they're struggling with, so that I can understand how to begin to move in a direction to treat it. And that's it. I mean, that's what we're all doing. And what's interesting is that when I when you first learn medicine, you have to do these really, really detailed histories and physicals. And you spend a lot of time with somebody to be able to get it done right. And it doesn't matter whether you're on a psychiatry unit or whether you're on an internal medicine unit. It is an exhaustive assessment of every possible thing that can be going on with that person. As you then progress into residency, you start to scale that down a little bit. You've either learned to ask better questions, you've learned to focus it in on something. As you become an attending, it's even less. And I think at some point, it gives way to the fact that, now sometimes you're not really getting much conversation. They're like, I saw your blood pressure, I saw this, I saw that. They're looking at numbers, and I think, I know I've been in my PCP's office and I feel like he's in a hurry, and, he's looked at all the numbers and he's telling me what he thinks. And I'm like, I don't want to bother him. That's the thing. That's the risk. I got to just, we all got to get past that and just start talking and saying the things that we need to say. So, I think if I was to identify one thing, it's that.
Yeah, I totally agree. And what a great message. And certainly thinking about the conversation we've had, communication has been that thread running through just about all of the topics we've covered. And so if by virtue of us having this conversation and communicating around these topics, that helps others to do likewise, then that's certainly a good thing. So we appreciate your feedback on that. And we appreciate your participating on this episode of the Behavioral Health Matters podcast. We wish you all the best going forward, and just want to say thank you again.
Yeah, thanks for having me. Glad to come back if you need me.
You bet. Thanks again. Stick around. We'll be right back to wrap things up. So what did we learn on this episode? Well, we learned that Magellan of Pennsylvania has a number of specialty programs designed to promote greater collaboration with providers and other partners to improve services and supports. We also learned that the medical director at Magellan of Pennsylvania, Dr. Chris Squillaro, plays a critical role in helping to oversee and facilitate clinical conversations intended to support providers' work and to improve member care. We'd like to thank our special guest, Dr. Chris Squillaro, for joining us on this episode and helping us to learn all about the activities of Magellan of Pennsylvania. We'd like to thank all of you for listening to this episode and invite you back for our next episode. If you have any questions or feedback about the podcast, or have suggestions for future episodes, please hit me up at jglees@magellanhealth.com. And if you like this episode, don't forget to hit that like button and subscribe to our channel for more Behavioral Health Matters content. Well, there's the music letting us know we've come to the end of another episode. I'm your host, John Lee, saying goodbye for now, but please remember, Behavioral Health Matters.